Hello, my name is Quentin Broussard. I'm an assistant professor of clinical sciences at California Health Sciences University, and today we will be discussing acute decompensated heart failure, or ADHF. And the reason we're discussing this topic today is that acute decompensated heart failure is an acute disease state resulting in significant morbidity as well as mortality, in addition to billions of dollars per year cost in America. As a pharmacist, it's important to understand the pharmacotherapy behind acute decompensated heart failure, as well as participate in discharge planning and counseling to minimize rehospitalization of these patients. Our objectives today will be to characterize acute decompensated heart failure, to review medications utilized for acute decompensated heart failure, classify acute decompensated heart failure based on volume and perfusion status, select pharmacotherapy for ADHF based on volume and perfusion status, and then prepare acute decompensated heart failure patients for discharge. So we'll start out with the case. HP is a 62-year-old female presenting to the emergency department with shortness of breath. She was just diagnosed with congestive heart failure 2 months ago and has been eating out at McDonald's every day. Vitals upon presenting include blood pressure 128/62, respiratory rate 28, heart rate 120, and oxygen saturation 89%. A Swan-Ganz catheter was placed, revealing a cardiac index of 3.2 and a pulmonary capillary wedge pressure of 22. Which of the following subsets best describes HP? Subset warm, 1, warm and dry, subset 2, warm and wet, subset 3, cold and dry, or subset 4, cold and wet. Question 2. Which of the following medication regimens should be started based on the subset selected in question 1? Dobutamine continuous infusion, intermittent IV furosemide, intermittent piometolazone, or Milrinone plus nitroglycerin continuous infusion. And question 3. After your intervention from question 2, PB's volume status has been optimized while in the hospital, and now she's about to be discharged from the hospital. Which of the following should you counsel PB about prior to discharge? Administration technique of IV diuretics at home, calling the provider if 1 pound of weight gain in a day, restricting sodium and fluid intake daily, or setting up inotrope therapy with a home infusion company. After today's talk, you should be able to answer each of these questions confidently. Just to give you a little bit of background, there are about 1 million patients hospitalized annually with heart failure. And in general, heart failure is associated with a 5-year mortality of about 50%, which is pretty significant whenever you think of morbidity and mortality terms. The cost of heart failure is estimated to be about $70 billion by 2030. And a lot of this cost is actually thought to be generated by acute care costs. So basically treating patients in the hospital versus treating patients on the outpatient side. So essentially, a lot of what is going to drive cost in the future, a lot of what is driving costs now is actually having patients in a hospital being treated for acute decompensated heart failure versus actual chronic management of heart failure. So what is acute decompensated heart failure? Acute decompensated heart failure is essentially known as a heart failure exacerbation or a CHF exacerbation. And it comprises new or worsening signs of heart failure. So whenever a patient comes in, they don't necessarily have to have a diagnosis of heart failure at the beginning, but they have to have some kind of symptomatology that requires them to be admitted to the hospital, ideally, to be considered ADHF. Or the patient can have pre-existing heart failure and just have worsening symptoms, which we will discuss a little later on. Essentially, acute decompensated heart failure is the result of fluid overload and or low cardiac output or index or hypoperfusion. So essentially, you have to have one or both of these criteria to meet a definition of acute decompensated heart failure. So you have to have either fluid overload, hypoperfusion, each individually, or you can have both of them together. And that can be considered acute decompensated heart failure. A little bit of background regarding the hemodynamics of heart failure, especially in patients who may have acute decompensated heart failure. As patients have mild, moderate LV dysfunction, transitioning to eventually severe LV dysfunction, you see here as the graph essentially goes down in terms of cardiac index, that these patients may very well be very fluid overloaded with a capillary wedge pressure greater than 18. And a capillary wedge pressure, or pulmonary capillary wedge pressure, also known as a pulmonary artery occlusion pressure, which we previously talked about, is essentially a measure of volume. So amounts greater than this 18 right here can potentially signify volume overload or pulmonary congestion. And this can get worse with severe LV dysfunction. Now, in terms of patients who have moderate to mild LV dysfunction or even severe LV dysfunction, their cardiac output may be stunted. And whenever they don't have as good of a cardiac output as a normal patient who has normal cardiac output, they will try to compensate through an increase in systemic vascular resistance to maintain their blood pressure. Because remember, our formula for blood pressure is equal to cardiac output times your resistance in the vasculature. So if one thing goes down, the other one must go up. And whenever we compare it to some of the other types of shock, we kind of see that trend here. So one thing in terms of cardiogenic shock, or basically shock relating to an inability of the heart to pump, is that we may see patients that have a low cardiac output, which is their primary problem, and try to compensate via an increased systemic vascular resistance to maintain normal blood pressure. Now, the other thing that is different about cardiogenic shock is that these patients will most likely, in a lot of cases, present with volume overload. And as a result, their CVP and their pulmonary artery occlusion pressure or pulmonary artery wedge pressure may be increased as a result of that. So as you can see here, it essentially presents very similarly to septic shock if the septic shock is hypodynamic, which, remember, we discussed hypodynamic essentially means a low cardiac output or cardiac index. In terms of the etiology of acute decompensated heart failure specifically, there are many different reasons patients may come in with acute decompensated heart failure. They may actually come in with a dietary indiscretion. So that means that they may have been intaking too much sodium or too much fluid in their diet. And all of this essentially increases your total amount of body water or your body volume that you have in your body. And this is a profound problem in patients with heart failure, because if a patient with heart failure who has a low cardiac output is not able to handle all that volume, essentially what happens is all of that volume starts to back up to all of the other organs. So instead of flowing forward it's actually flowing backward. And as a result, that's why sodium and fluid are not good for these patients. Fluid, obviously, because fluid kind of relates to water and body water volume, essentially. Sodium is not great for these patients in excess amounts because sodium actually attracts water. If you think about the different water compartments that we have and the effect that sodium has on them. Another etiology of acute decompensated heart failure is NSAID use. NSAID use may not only do damage to the kidneys, but it may also promote potential fluid retention, which is kind of the same issue with the dietary indiscretion that we discussed here. Non-dihydropyridine use. So agents such as diltiazem or verapamil may actually induce heart failure. And this is because these agents are what are known as negative inotropic agents. So they essentially will decrease the ability of the heart to contract properly. So if you have a patient who has heart failure that is on one of these agents, ideally these agents should be converted to something else. Another one is medication non-adherence. So if your patient is not being very compliant with, for example, their diuretic or some of their other long-term medications that they are using for heart failure, such as ACE inhibitors, ARBs, etc., they may eventually develop acute decompensated heart failure, essentially just from not taking care of themselves. Some other acute instances that may induce an acute decompensated heart failure include infection, which includes eventually sepsis down the road if the infection gets really bad. Myocardial infarction, because any kind of damage to the heart can prevent the heart from pumping properly. Atrial or ventricular arrhythmias can also lead to eventual heart failure. Hypertensive crisis can make it also difficult for the heart to pump properly. Myocarditis, or an inflammation of the heart muscle, can make it difficult for the heart to pump. In addition to acute valvular insufficiency, so some kind of problem with the patient's valves, or even symptomatic hypo or hyperthyroidism, because we know that there are many different hormones that play a role in the regulation of the heart. And thyroid hormone is one of those. So if you have a patient who's either hypo or hyperthyroid severely, it may actually manifest in a heart failure exacerbation. In terms of the patient presentation, all patients with heart failure will actually present differently. So depending on that type of patient that you have, they may have very specific symptoms based on their different lab parameters. So one thing that patients can potentially present as is fluid overloaded. And this can manifest in a weight gain, and typically it's a significant weight gain, which may be considered greater than 5 kilograms from their dry weight, but it actually can be even less than that. That will tip them off into becoming in an acute decompensated state. Another thing that you may see is patients that may have some kind of problems breathing on exertion or at rest. Problems whenever they lie down and try to breathe. Quick breathing as well. You may see patients in their physical exam have jugular venous distension. They may have crackles whenever you do an auscultation of their lungs. Hepatomegaly, which is essentially a result of congestion of the liver. Lower extremity edema as a result of that backup of fluid that we were talking about. Whenever the heart is not able to pump forward, it pumps back. And one of the areas that actually accumulates fluid are the lower extremities, as well as extreme fatigue. Certain patients may also present with low cardiac output. And this can manifest as hypotension, cool extremities, because essentially the heart is not pumping blood forward as well, and as a result may not be getting warm blood to the extremities, and that's why the extremities are cool. If you have patients with low cardiac output, they also may present with worsening renal function and worsening hepatic function as a result of patients not getting blood to those vital organs. And in terms of the worsening renal function, in the setting of low cardiac output, that's actually referred to as cardiorenal syndrome. You also may see organ hypoperfusion, just as we mentioned, which may manifest as altered mental status, uncontrolled hypertension in some cases, as well as a myocardial infarction or a heart attack. So now that we talked a little bit about the background of acute decompensated failure, what are our goals of treating acute decompensated heart failure? Well, we want to provide symptomatic relief to these patients. Our goal is not necessarily to cure their heart failure, but to try to minimize the symptoms that they have related to their heart failure, whether that be fluid overload, low perfusion, or organ dysfunction. We want to try to optimize their volume status and their cardiac output and their cardiac index. So we want to make sure that these patients are not fluid overloaded and they have adequate perfusion to the rest of their body. We want to minimize adverse effects related to ADHF pharmacotherapy, because a lot of the agents that we're going to talk about can actually have some pretty harmful adverse effects, depending on which agent you're talking about. We want to evaluate for precipitating factors of the actual ADHF episode. So basically, we want to look in terms of the etiology, and we want to try to correct that either in the hospital or prior to discharge. Say if it was some kind of environmental factor or some kind of factor that can be mediated by proper counseling or further assistance on the outpatient side. We want to assess the patient's profile for medications that may worsen heart failure. So some of those things that may worsen heart failure from the medication side include things like the non-dihydropyridine calcium channel blockers, as well as agents such as pioglitazone or rosiglitazone, especially if they are used in stage 3 or stage 4 heart failure. And prior to discharge, we want to make sure that we optimize the patient's chronic oral therapy and provide patient education to the patient where they need in terms of their diet or their medications in order to prevent rehospitalization. So the goal essentially at the end of this is to try to prevent the patients from coming back to the hospital. We want to make sure that the patients live, long and healthy lives, even though they do have a diagnosis of heart failure. There are many different classes of pharmacotherapy used to treat acute decompensated heart failure. We have the loop diuretics, the thiazide and thiazide-like diuretics, inotropes, and vasodilators. The first group of medications we'll talk about are the loop diuretics. So you may be familiar with the loop diuretics from your previous talk about chronic heart failure. And just a reminder, loop diuretics include medications such as furosemide, torsemide, and bumetanide. And these are listed in order of increased potency. These agents are first line for patients that have any kind of volume overload related to their heart failure. And they're typically administered intravenously in acute decompensated heart failure, though in some patients an increase in their PO dose may actually help as well. Some adverse effects that occur as a result of loop diuretics include intravascular volume depletion, which can lead to possible hypotension, obviously from the action of the drug. We're trying to get volume off of these patients. Renal dysfunction can also occur as a result of volume loss. You can develop prerenal azotemia as a result of this. Dizziness, if you lose too much volume, you may even see some orthostatic changes in these patients. Photosensitivity Photosensitivity is a side effect that goes along with a lot of the diuretic agents. You may develop a metabolic alkalosis, which is associated with overdiuresis, which may occur if you give too much of a loop diuretic, either as intermittent dosing or as a drip. And you also may see many electrolyte disturbances with loop diuretics, some of the main ones being hypokalemia, hypomagnesemia, and hypocalcemia. Whenever you're comparing Lasix, Demodex, or torsemide, and bumetanide or Bumex, it's important to know how each of these medications is provided, their bioavailability, and in terms of their doses, how can you convert between agents, especially whenever the patient's either coming into the hospital and you need to give a stronger dose of the diuretic or a diuretic that they were receiving compared to their outpatient dose, or even going home, transitioning them to some kind of PO diuretic dose. So it's important to note that of the agents here, all of them are PO and IV in terms of formulation, except for torsemide, which only the PO is available. In terms of torsemide and bumetanide, they have bioavailability close to 100%. So in terms of their dose conversions between PO and IV, they're pretty much 1-to-1. So if you give 20 milligrams of torsemide PO, that's equivalent to 20 milligrams of torsemide IV. And the same can be said with bumetanide. 1 milligram of bumetanide is equal to 1 milligram IV of bumetanide. So the PO and the IV are essentially the same. Furosemide is a little different though. Because the oral bioavailability of furosemide is 50%, that means that whenever you convert from PO to IV, you essentially have to cut the dose in half. So essentially in this case, 80 milligrams PO of furosemide is equal to 40 milligrams of IV furosemide. It's important to realize their dosing conversions, as these may play an important role in the transitions of care of your patient. You also have standard intermittent IV dosing that can be used. In terms of furosemide and bumetanide, since they are the agents that have IV formulations, they are used the most. And you can see their usual intermittent dosing here. Another big thing that is available in terms of furosemide and bumetanide are continuous furosemide and bumetanide drips. And these are typically used if you need aggressive volume taken off of the patient, or if the patient is not properly responding to intermittent doses of your loop diuretic. And the traditional doses are shown here. As you can see here, these are not bolded, so these are not medication doses I would expect you to know. However, I would expect you to know how to convert between furosemide, torsemide, and bumetanide, as well as the oral bioavailability and administration routes. The next class of pharmacotherapy in terms of ADHF that we're going to talk about are the thiazide and thiazide-like diuretics. And these include hydrochlorothiazide, chlorothiazide, and metolazone. These agents are typically used in patients who are resistant to loop diuretics alone. This phenomena is also known as diuretic resistance. So essentially, these patients have to be on a loop diuretic already before you actually use the thiazide diuretic. So these medications are actually used in combination with loop diuretics. And that is important to note. They should not be used monotherapy in patients with acute decompensated heart failure. Also, this combination is only typically reserved for hospital usage as a result of potential adverse effects that may occur with the combination use of these agents. In terms of adverse effects, you may see renal dysfunction, dizziness, photosensitivity, hyperuricemia, which may be problematic in patients who have gout, as well as electrolyte disturbances. So essentially, the adverse effects are very similar to those that you see with the loop diuretics, other than the hyperuricemia piece, which you see commonly more with thiazide and thiazide-like diuretics. In terms of the different agents that we have here, most of them are available PO. The one that is available PO and IV is chlorothiazide or diuryl. In terms of the bioavailability, you see them here, as well as the usual intermittent dose of these agents. None of these agents is provided as a continuous drip. The next set of agents we will talk about in ADHF pharmacotherapy are the inotropes, Dobutamine and Milrinone. So we'll start out with Dobutamine. So similar to a lot of the other vasopressors that we talked about, Dobutamine is a catecholamine agent, and it primarily activates beta 1 and beta 2, and it has minimal alpha activity. So whenever you think of this agent, you primarily think of it acting on the heart as well as on the lungs. So in terms of the beta 1 effect, it causes chronotropy, inotropy, and dromotropy. In terms of the beta 2, it causes bronchodilation. But remember that beta 2 is also found on our periphery, which will actually cause vasodilation. An important note with this medication is that its half-life, just like many of the other vasopressors, is very short. It's only 2 minutes, so it's easily titratable, so you can titrate it on or titrate it off. The traditional dosing for this agent is between 2 to 20 mics per kilo per minute, and you should titrate to effect. The maximum dose is 20 mics per kilo per minute. In regards to adverse effects, tachycardia may result as a result of the beta 1 effect. Hypotension may also result from beta 2 effect that dobutamine has. So you should think of dobutamine as an inodilator, as it will inodilate. However, this is traditionally seen more at the higher doses. So, in regards to giving dobutamine in a patient that has hypotension already, for example, it may actually benefit them to give the patient dobutamine even if the patient is hypotensive, because remember, our blood pressure is also governed by our cardiac output. If we improve cardiac output, we can improve blood pressure. However, if blood pressure gets worse, you should probably decrease or discontinue the dobutamine. In addition, you may see ventricular arrhythmias occur as a result of the beta 1 effect. The other inotrope agent that we will discuss is Milrinone. And Milrinone is a phosphodiesterase 3 inhibitor, which is vastly different than all of the other agents that we've talked about vasopressor-wise, and also very different than dobutamine because it does not activate any alpha or beta receptors. What it actually does is it will inhibit phosphodiesterase 3, which will eventually lead to increased intracellular concentrations of CAMP, which eventually will go and stimulate calcium release from the sarcoplasmic reticulum in the cell. And that calcium will eventually go to work in activating action potentials of certain areas of the heart and cause contraction. As a result of that calcium release, it does produce inotropy, chronotropy, and dromotropy just like dobutamine does. However, the flaw in this agent is that the half-life is between 2 to 4 hours, so it actually takes a lot of time for this agent to have its full effect. So if you're looking for immediate effect, you might want to go to dobutamine first. As a result of its long half-life, we actually give a bolus dose of this medication followed by a continuous infusion. So 50 microgram per kilo bolus is given, then a continuous infusion of anywhere from 0.1 to 0.75 mics per kilo per minute is given. And you can titrate to effect with this medication. Another important note with this medication is it does eliminate renally, and as a result, it accumulates in renal dysfunction, which can worsen some potential adverse effects, especially if your patient has end-stage renal disease. And those effects can potentially be hypotension, ventricular arrhythmias, as well as headache, which headache is more of a minor one whenever we compare it to the other two. The next agents we'll talk about are the vasodilator agents: nitroglycerin, Nesiritide, and Nitroprusside. Nitroglycerin is essentially converted to nitric oxide in the body, and nitric oxide is a vasodilator endogenously. Specifically, nitroglycerin is primarily a venous dilator, though it may produce some arterial vasodilation at higher doses. Nitroglycerin primarily reduces preload, or that volume of blood essentially coming back to the heart, though it may reduce afterload at high doses. So essentially reducing that systemic vascular resistance and that force to overcome to eventually pump blood forward. Its half-life is very short. Its half-life is 1 to 3 minutes. And dosing is anywhere between 5 and 200 mics per minute and titrate to effect, depending on what effect you would want. This agent also used in other disease states such as acute coronary syndromes, as well as hypertensive crisis. So depending on what indication you're actually using it for, that's what essentially titrate to effect means. Whether you're trying to titrate to effect of blood pressure, titrate to effect of chest pain or angina, or if you're trying, in the case of acute decompensated heart failure, to titrate to the effect of perfusion. In regards to nitroglycerin, some of its adverse effects include hypotension, which is one of the cases where you should not actually use nitroglycerin if you have a patient who's already hypotensive, because it will lower your blood pressure even more. Bradycardia may also result, headache, as well as reflex tachycardia, and this typically occurs upon discontinuation of nitroglycerin. Nesiritide is another agent you can use as a vasodilator. It acts primarily as an arterial, venous, and coronary vasodilator. And as a result, it reduces preload, afterload, and increases cardiac output. All this without direct effect on the heart or direct inotropy. It does have a slightly longer half-life than some of our other agents, so the half-life is 18 minutes. As a result, you have to give a bolus dose to try to get to steady state quicker, followed by a continuous infusion. And this, again, is titrated to whatever effect that you're aiming to see. In regards to Nesiritide, some adverse effects include hypotension, increased serum creatinine, headache, nausea and abdominal pain, as well as dizziness. The last vasodilator we'll talk about is Nitroprusside. It is a nitric oxide donor, and as a result, it acts as an arterial and a venous vasodilator. And this reduces preload as well as afterload. Like a lot of the other agents we've talked about, the half-life is only about 2 minutes, so very, very short. As a result, you don't have to bolus dose it. It's a continuous infusion ranging from 5 to 300 mics per minute. Again, it's titrated to effect like the other agents. Of note, the maximum dose is 2 mics per kilo per minute. So you'll notice that the actual dosing max units here are different than the continuous infusion units here. So make sure that you check the weight of your patient whenever you're giving this agent. depending on your institution and how they like to dose nitroprusside. Some adverse effects of nitroprusside are hypotension because it's a vasodilator. An important thing that is very significant regarding nitroprusside is it does cause cyanide and thiocyanate toxicity, and this can actually manifest as a metabolic acidosis. That's why in a lot of cases we want to try to limit the duration of our nitroprusside therapy use. Some hospitals will actually limit nitroprusside to only be administered for 48 hours as a result of the risk of this cyanide and thiocyanate toxicity. You may also see EKG changes as a result of nitroprusside, as well as methemoglobinemia, which happens more rarely. And that methemoglobinemia is essentially the conversion of regular hemoglobin to methemoglobin, which does not carry oxygen throughout the body as well, and these patients actually present in respiratory distress. Again, methemoglobinemia is rare, does not happen very often, but it is something that may occur with nitroprusside. So you should be aware about it if you have a patient who presents with methemoglobinemia. Now that we talked about the different agents that we have, we're about to apply each of those agents to when the patient actually comes into the hospital. However, we should know a few things about what we should do with the patient's outpatient regimen first. So whenever we have a patient who has CHF, and we already know about the diagnosis beforehand, we should, do a few things first prior to continuing their medications in the hospital, which could actually worsen their outcomes. So in terms of transitioning a patient from outpatient to inpatient, so basically from real life to the hospital, aggressive diuresis should be done if patients are fluid overloaded upon physical exam. So this includes conversion to IV diuretics, which is often necessary with a higher dose compared to their outpatient dose. So say if you have a patient who comes in and is on furosemide 20 milligrams PO daily, and they are fluid overloaded upon exam, then you might actually want to convert that furosemide 20 PO to furosemide 20 milligrams IV, which will actually be a more potent dose of furosemide, or even higher, depending on the degree of fluid overload. In terms of beta blocker doses may be reduced or held if there was a recent dose adjustment, or if the initiation caused a decompensation. So say if your patient started a beta blocker recently, for example, or if you had a recent dose adjustment up, and your patient decompensated, you might actually want to reduce or hold further beta blocker doses until the acute decompensation is over. In the event that your patient presents with low urine output, less than 0.5 mils per kilo per hour, or if they present with hyperkalemia, you may want to hold ACE inhibitors, ARBs, aldosterone antagonists, and neprilysin inhibitors such as sacubitril, because some of these agents will actually make these things worse. In regards to digoxin, discontinuation of digoxin per your book is generally not encouraged unless therapeutic digoxin levels cannot be maintained. So if you have a patient, for example, who has renal failure and they are not able to eliminate digoxin as well, that might be a case where you actually stop digoxin, because in that case, digoxin might accumulate into super therapeutic levels, and that may actually result in digoxin toxicity. In regards to the treatment of acute decompensated heart failure patients, they all fall within one of four subsets. They can either be normal, which in that case, they actually don't even have acute decompensated heart failure. So this is ideally our goal here. They may present with pulmonary congestion, which is subset 2. they may present with hypoperfusion, which is subset 3, or they may present with both pulmonary congestion and hypoperfusion, which is subset 4. And the cutoffs for each of these subsets is, in regards to cardiac index, which you see on the y-axis here, is less than 2.2 liters per minute per meter squared. And in terms of the x-axis, pulmonary capillary wedge pressure is 18 millimeters of mercury for your pulmonary capillary wedge pressure, or your pulmonary artery occlusion pressure. So depending on where they fall in terms of their different lab parameters, that actually will dictate what category they actually go into. Now, breaking that down a little further, depending on what category they go into actually determines what medications they should receive. And as you see, this schematic is very complicated, but all of this information is important to know because it will essentially govern what you do next in terms of your patient. So the first step you should do is you should classify your patient via subset with your pulmonary capillary wedge pressure and a cardiac index. So starting with subset 1, which is our warm and dry patients that we see here, they have a cardiac index greater than 2.2 and a pulmonary capillary wedge pressure of less than 18. So these patients essentially are not volume overloaded because they don't have a high enough pulmonary capillary wedge pressure, and they are not hypoperfused because they have a cardiac index which is still relatively normal. And remember, our normal range for cardiac index is 2.5 to 4. However, anything above 2.2, you probably will not be very symptomatic. Just depends on the patient. These patients don't require immediate intervention other than optimization of their guideline-directed medical therapy. So basically, optimization of their ACEs, their ARBs, their neprilysin inhibitors, their diuretics, etc., etc., etc. We get a little more complicated whenever we get to subset 2, which is the patients who present as what we call warm and wet. So these patients are still maintaining good perfusion cardiac index-wise, so they still have a cardiac index greater than 2.2. However, they do present with pulmonary congestion, which is a result, which actually may present as a pulmonary capillary wedge pressure greater than 18. So in these patients, what we want to do is we want to try to minimize the volume burden that these patients have. And we want to essentially initiate loop diuretics to reduce preload via diuresis. So we want to essentially get rid of that volume that these patients have on them because they are very pulmonary congested. And or we may vasodilate these patients with the vasodilator. And what these vasodilators do is they act essentially as preload reducers by increasing venous capacitance, thus reducing the symptoms of pulmonary congestion, especially in patients who have high ventricular filling pressures, which you can kind of see adjunctly with the PCWP greater than 18. One important thing to note with these patients is it's important not to use vasodilators in patients with a systolic blood pressure less than 90. And I probably wouldn't use them in a MAP less than 65 either, as these patients are already hypotensive and their hypotension will get worse if you administer a vasodilator. So primary treatment here is most likely loop diuretics, though you can still use vasodilators as an alternative. If your patient is refractory to loop diuretics, in terms of intermittent loop diuretics, you may initiate a continuous loop diuretic drip, or you may even initiate a thiazide or thiazide-like diuretic if diuretic resistance occurs with the loop diuretic alone. So essentially, you may start hydrochlorothiazide, chlorothiazide, or metolazone on these patients if they have diuretic resistance. In regards to patients in subset 3, these patients end up being cold and dry. So essentially what cold means here is that the cardiac index is less than 2.2, so they're not perfusing very well. And their pulmonary capillary wedge pressure is less than 18, so they're not congested. They essentially fall in this little quadrant here. So in terms of these patients, if they appear dry and cold, emphasis on the dry here, if the patients are dry enough where hypovolemia exists, so say if you have a patient with a pulmonary capillary wedge pressure less than 15, for example, or if they have orthostatic hypotension, these patients actually may need IV fluids. And this will actually potentially help boost their cardiac output by giving them IV fluids. Our goal pulmonary capillary wedge pressure in these patients is between 15 and 18 in this case. Now, if a patient comes in hypovolemic, and a lot of times this hypovolemia actually results from overdiuresis, you will want to hold patients' diuretic therapy until their volume status is back a little bit up again. And then you can restart their diuretic therapy that they were on if they were on diuretic therapy before. Now, if fluids are not needed, so if your patient does not meet either one of these criteria, you can actually start a continuous vasodilator or an inotrope to essentially try to increase this patient's perfusion. Vasodilators are preferred. However, they should not be used in patients, again, who are hypotensive with a systolic blood pressure less than 90 or a MAP less than 65. If that is the case, then you should use an inotrope first. Now, in terms of patients who fall into subset 4, which is essentially the worst subset for outcomes, these patients are cold and wet. They have a low cardiac index of less than 2.2 and a pulmonary capillary wedge pressure greater than 18. They present with both pulmonary congestion and evidence of hypoperfusion. Now, in regards to these patients, they need to be started on some type of dual therapy. If their systolic blood pressure is greater than 90, then you can use a vasodilator and a loop diuretic together. Because remember, we need to get the volume off these patients, that's why the loop is done. And then we want to try to increase perfusion. So in that case, we can use a vasodilator. However, if your patient has a systolic blood pressure less than 90, you can't do a vasodilator at that point because it will just bottom out your patient. In that case, you will want to initiate an inotrope, such as Milrinone or Dobutamine, and a loop diuretic together. So bringing all this back together in terms of your subsets, again, here are your treatments. And essentially the slides kind of summarize the recommendations from here. The main parts I want you to get from this are basically, first and second line, what would you do in terms of if your patient was classified in one of these subsets. Now, say what happens if your patient has very poor perfusion and you try pharmacotherapy and pharmacotherapy does not work. In that case, mechanical circulatory support, or MCS, may actually be indicated for these patients. In terms of the available mechanical circulatory support that is available, the devices that are currently around include intra-aortic balloon pumps, which are IABPs, ventricular assist devices, which are also known as VADs, and extracorporeal membrane oxygenation, also known as ECMO. Now, we won't go too far into each of these different devices as they're very specialized, though you may come across some of these agents while in practice. Some of the important things to remember regarding these different devices is that a lot of them will actually help the heart to pump better. So essentially, what a lot of these different modalities can do is help your heart pump better. As you see here on the right side in this diagram, this is actually a picture of an LVAD, a type of ventricular assist device, which actually will help the left ventricle pump better in patients who have pretty much end-stage heart failure. Some other important things about these devices in general is some of them might require anticoagulation, so things such as heparin drips or even chronic warfarin therapy. Whenever I worked during my residency at a cardiology hospital, we had a lot of patients on these ventricular assist devices, and they actually require chronic anticoagulation with heparin and eventually to warfarin as a result of the stasis that is occurring in the heart and the stasis that can be generated by these different devices. Some of them also, depending on where you're at and where you practice, may also require antibiotic prophylaxis with agents such as vancomycin, though the data on that is not that great. So that's just a little intro into mechanical circulatory support. I wouldn't expect you to know anything about this type of stuff on an exam, but I just want you to kind of get an exposure of what these actual devices are called and essentially what they have the potential of doing. Now on the flip side to that, if your patient actually gets better, and that is the goal that we want the patients to meet, we want to prepare them for discharge. So upon preparation for discharge, we want to make sure that our goal is to make sure that their ultimate volume status is achieved by discharge. So we want to make sure that these patients don't go home overloaded and that their IV diuretics are converted to PO, because it is very difficult for a patient to give themselves IV medications at home unless they have special assistance. Now, inotropes such as Milrinone and Dobutamine can actually be continued at home, assuming that the patient is stable and they're done at fixed doses. There are a lot of home infusion companies that will actually help facilitate this process. And prior to discharge, a conversation should be had with a case manager who can assist in setting up this process so that the patient does not have to do it on their own and they can get the medication they need before they leave the hospital. In addition, in terms of preparation for discharge, the following should be documented in the medical record. A patient's left ventricular ejection fraction, or LVEF, should be documented. Whether or not they are on an ACE inhibitor and beta blocker, or an ARB and a beta blocker, or a neprilysin inhibitor plus an ARB. These patients should be on these agents as they are known to improve outcomes in patients who have heart failure due to reduced ejection fraction, or HFrEF. And if they are not on these agents, they need to have a documentation of why they are not on these agents, such as an intolerance. Patients should also receive smoking cessation counseling if they are smokers, as this is related to poor cardiovascular outcomes. In addition, regarding counseling for patients, it's important to counsel patients to monitor their daily weights. So before they leave the hospital, make sure that they have a scale at home, or make sure that they can get a scale. And if they gain more than 2 pounds in a day or 5 pounds in a week, they need to call their provider, because at that point they are starting to accumulate too much fluid. And that fluid can eventually build up on their lungs, on their periphery, on their abdomen even, and cause many problems with the patient breathing, as well as swelling, which may impair the patient from moving properly. Some of this weight gain may be mediated through a sodium and fluid restriction. So sodium restrictions such as less than 2 grams per day of sodium, or even less than 1,500 mils per day of fluid, or even 2 liters of fluid, though in my experience, telling patients a much lower volume may actually help in regards to fluid restriction. So say if you tell a patient that they should do less than 1,500 mils of fluid in a day, they may actually go out and do a little more than that. However, that little amount may not be harmful to them. It just depends on the patient, how much that patient is able to tolerate. But whenever you talk about sodium and fluid restrictions, your goal should be reasonable to the patient, as well as reasonable to the provider, to minimize fluid overload and minimize rehospitalization. Here are the references for this talk today. And in regards to the case questions, so we had HP. She was a 62-year-old female. She came to the ED with shortness of breath. She has a history of CHF and has been eating out of McDonald's every day. So very salty diet. Her vitals in terms of blood pressure are normal, but her respiratory rate and her heart rate are elevated. Salon scans revealed a cardiac index of 3.2, which is normal, and a pulmonary capillary wedge pressure of 22, which is above normal. Which subset best describes HP? The answer here is warm and wet. The reason they are warm and wet is because this patient has a cardiac index of 3.2, which is above our threshold of 2.2. So that means that they are warm, so they are not cold. In regards to their pulmonary capillary wedge pressure, it is 22, which is greater than our threshold of 18, which makes that patient wet. So this patient is essentially subset 2, warm and wet. Question 2, which of the following medication regimens should be started based on the subset selected in question 1? Answer here is intermittent IV furosemide. And this is the correct answer because we're actually trying to minimize volume overload on our patient. The options that include Dobutamine and Milrinone are not correct because this patient does not have any necessarily perfusion issue because their cardiac index is still good. They are not cold, so they don't need an inotrope. And intermittent piometolazone alone should not be used, as these agents, the thiazides or thiazide-like diuretics, should be used in conjunction with a loop diuretic. Last question. HP's volume status has been optimized while in the hospital, and she's now about to be discharged from the hospital. Which of the following should you counsel HP about prior to discharge? The answer here is to restrict sodium and fluid intake daily. HP should not be getting IV diuretics at home. And if she does get IV diuretics at home, she should not be administering them herself. In regards to weight gain in a day, the cutoff traditionally is 2 pounds of weight gain in a day or 5 pounds in a week. Is a couple of well-known standards that are used by many providers. The last option, set up inotrope therapy with a home infusion company. We said that she was warm and wet. She is not cold, so she does not need inotrope therapy. And ideally, this should not be the case for many of the patients unless they are stable and they are cold upon discharge. So ideally, we should not be getting to this point unless the patient is already at end-stage heart failure. It's important to restrict sodium and fluid intake daily to minimize volume overload and pulmonary congestion. If you have any questions, please feel free to contact me. Have a great day.